I'm Lynn Eckhert, and I graduated from State University of New York at Buffalo Medical School, and then I have a Doctor of Public Health from Johns Hopkins School of Public Health.
What year did you graduate from medical school?
1970.
1970. Now, I almost feel like we need to stop right there and just talk about that experience. How many of your classmates were women?
There were 9 out of 100
Wow.
of us.
Wow.
And there were 10, and one left in about the first month. And then the rest of us all graduated.
Yeah. So what drew you into medicine?
Well, the interesting thing is I was a nurse before I went to medicine. And my father is a surgeon, and he said, girls don't go to medical school. So I went off and got a master's in nursing and said, I think I really should be a physician. So right after nursing school, I went to medicine. I had to take one course in organic, and then I got into medical school afterwards and just went through medicine. I knew that that was a better decision for me.
Okay. What was it that drew you to wanting to be a physician with that uphill battle of society in terms of not really having women physicians?
Well, you know, I obviously admired what my father did, and I must have been very competitive with my brothers. I was one of 5. I'm in the middle of 5, and my older brother became a physician. And I just thought, I'm as smart as he is. I can do this. And once I got into medicine, my father was very encouraging, but he was not encouraging that I should make that as a career choice. So it just seemed like the right thing to do. I liked working with people. I liked medicine. We sort of grew up with medicine, went on hospital rounds as children, and then worked in the hospital in the summers and things like that. So it was a very comfortable environment, and it was a profession that I admired.
So how did your male classmates treat you?
Well, first place, I wouldn't say it was as much an issue with the classmates as it was more of an issue with some of the professors. And there was one professor who called us the hen meds, and he was an anatomy professor. Interesting enough, he was married to a woman physician, and he was an MD, PhD. But you knew, we went to school 6 days a week. We went Saturday mornings, and on Saturday mornings we'd have these anatomy quizzes, and we were broken down into 3 groups, a third of the class, and you had different professors come and ask questions. And it was always sort of a really grilling session, and you always knew that the head of the Department of Anatomy, O.P. Jones was his name, all the women knew that when you had him, he would call on you. And he would often try and get you in more of a little embarrassing questions for women. And that was sort of the setup, and you just knew that that's how it was going to be.
Do you think, just out of curiosity, do you think there was ill motivation on his part, or that it was more of he wanted to push you to be better?
I think he was just trying to be entertaining.
Okay.
And clever.
Yeah.
Right?
Yeah.
He loved the stories about himself. Because he went to medical school late, he was already a professor of anatomy, and there were always these lores about him, and he liked to perpetuate them. I didn't think it was, really ill feeling, but it was obvious. We all knew it.
So what was residency like? Where did you go?
I had an interesting time in residency because I did my first year at the Cleveland Clinic in medicine because I wanted to do another year of medicine, but I knew I wanted to do pediatrics. But I think that medicine is just a wonderful introduction to all of the field of medicine, and it's something that we all should know more about. So I went to the Cleveland Clinic, but then I got married to Lewis while I was an intern. So then I went and he would have been drafted, and so then he went to the Indian Health Service, so I went out to Oklahoma. So going from the Cleveland Clinic to University of Oklahoma Children's Hospital was a huge difference. One was extraordinarily organized, very well resourced. Then I went to a university hospital that was run by the state, that had much more meager resources, but had both of them had a wide variety of patients in terms of the diagnostics. They were fascinating, although the Cleveland Clinic did not have as many of the poor people as Oklahoma. Took care of everyone, and had the volume and the pathology at Oklahoma was extraordinary. They thought I was a liberal from the East. I said they'd never really met one if they thought I was one. And so I only spent 1 year there because my husband finished the Indian Health Service, and so then we could leave, and we really wanted to go back east, so we went back to Hopkins and became Robert Wood Johnson Clinical Scholars and got an MPH. Both of us got an MPH. I stayed on for a doctorate and finished our pediatric residency in the Hopkins system instead. So there was a big difference. Tremendous amount of learning at Oklahoma, though, because of just the amazing volume of patients. For example, I had one little boy who had, a 4-year-old boy, who had tetanus. Now, I had been in Africa working on a couple of occasions for the summers, once after my first year of medical school and once after my first year of residency.
Okay. So Oklahoma, the 4-year-old boy.
The 4-year-old boy, right, and he had tetanus, and I had seen tetanus in newborns in Liberia, West Africa. So now I had a case of tetanus in the United States, which was almost unheard of. So we had a real variety of cases because it was such a large catchment area in the West compared to where there are many more hospitals in the East Coast. So anyway, then we came back and went to Hopkins. And that worked out very well.
Now, did you have an interest in getting an MPH going back, or did you do that?
When I went to Liberia after my freshman year in medical school, and I worked in a small mission hospital, and there was only one other physician. I wasn't a physician, but I had to function in many ways. I was functioning much more beyond my nursing level, but I had a combination of some medical school. And it was very obvious to me that although taking care of the individual patient was very exciting and very fulfilling, the impact you're going to make had to be more with the skills and tools that you learned from the Master of Public Health. That was really very clear. Because treating an individual case of tetanus or preventing tetanus, that kind of an example, or malnutrition or things like that, measles, very common. So I knew after that experience I wanted to get a Master of Public Health right away. That was a life-changing experience.
Now, was that common to have that international experience in your medical school? How did that opportunity come about?
Well, no, it was not common. But at the time, what HHS now was HEW, Health, Education, and Welfare, and they gave $600 scholarships to students to do something. I don't know if it was all students or just medical students. So I got for $600, and what happened is the minister of my church was head of the World Council of Churches, and so he was a very good friend of my family. His daughter was a friend of mine, and he was a friend of my father's. And I just called him and said I'd like to go somewhere. Now, I think in my mind I was thinking those were the 60s. I was going to go to Mississippi or something during the civil rights, but I kind of left it open, and he called me back and he said, okay, you're all set, you're going to Liberia, West Africa. Now, I had to figure out which one of those countries that was, to be perfectly honest. And so I went, and it really did make the difference of expanding how I looked at medicine in the long run, and what happened in my own career, which is very different than the average physician. Because I did not have the large practice of medicine, of taking, I'm a pediatrician, but I didn't have a large pediatric practice. I had a smaller practice, and I got much more involved in administration and in some public health and international programs right from the beginning.
Well, it really was a very profound impact of that experience.
Absolutely. But you asked me about how many people, went. Like now about 30% of the medical students do something overseas. But in my class, there were 2 of us, 2 out of 100 that went into more of a developing world. Maybe 1 or 2 people may have gone to England or something like that. But as far as going to the developing world, there were only 2 of us. And our classmates thought we were a little strange.
Yeah. How was that experience over there, just in terms of being accepted as a medical student, as a woman? What was that like in Liberia?
Well, in Liberia, I went to the same place twice. Once, the second time Lewis came with me. But the first time I went by myself. And when I arrived, they knew I was a nurse, but I was a med student, had finished my first year. So there was a sort of debate by the physician and the nurses where to put me. And the nurses said, look, she wants to be a doctor. She should go with you. Well, the nurses became my very good friends and buddies and the people I spent a lot of time with, after hours. But I got along extraordinarily well with this young physician. Well, physician, he was middle-aged actually. And he sort of took me under his wing and taught me a lot. And he was very, very helpful. And I think I was eager to learn, and he was eager to teach. And so it was a very nice combination.
So you moved to Worcester after you got your MPH.
Yes.
Where are you originally from? New York?
I'm from Buffalo, New York.
You're from Buffalo, New York. So what was your hope, what was your goal in terms of moving to Worcester?
Well, when we were leaving Hopkins, we had some really wonderful opportunities. We could have stayed at Hopkins, we could have gone to Virginia, University of Virginia, Michigan, or University of Massachusetts. And we sat down with our chair, and his name was Harold Harrison. He was just an outstanding person and a researcher in vitamin D and calcium. And he said, you're young, you don't have any children, you ought to go to the most risk-taking place because you will have better opportunities. And that was UMass. And UMass, that was in 1975. It opened in 1970. We could still drive up to the building, and the parking lot was mud. It was a mess. But you could park right there. It was very, very different. And so we started there, and Lou was working on that new health center, and I was working on a Robert Wood Johnson funded project on pregnancy risk, and with a fellow named David Kessner. He recruited me, and we were in the same department of family medicine. And very early on, the dean of the medical school, Roger Bulger, recognized that I had some sort of leadership talent, I guess, potential. And so they asked me to be chairman of the admissions committee and an assistant dean for admissions. And then by 1984, I was acting chairman of the Department of Family Medicine, and then I became the department chairman, and I did that until 1997. So I had a different skill set, I guess, than that they were looking for in a new school, and it was a wonderful opportunity. I was the only woman chairman for all of that time. There was somebody who'd been an anatomy chairman for a very short time, and then she was gone, and then I was the chairman of family medicine, the only clinical chairman up until 1997 when I stepped down, and then somebody else in pediatrics became a chairman. But so I was sort of in this man's world all the time, and you learn how to function. And one of the ways you learn is humor.
Right.
Humor to and also you had to really set your goals of what you wanted done. And University of Massachusetts was founded as a university that was supposed to be training primary care physicians. And when we were trained at Hopkins, that was our goal. That's what we were trained to do also. So we come to UMass, and at the time that I took over the chairmanship, only 3% of the class, it was just the lowest, went into family medicine. 3%.
Wow.
So I said, okay, we've got to increase this. And I set as a goal what the Academy of Family Medicine was saying was that half of people graduated from medical school should go into primary care. So 50% of the students, and of that, half of them should go in family medicine. And so that was my goal, and we hit it. We hit it in about 96 or 97, and I told everybody when we hit it I'd have to step down because I wasn't sure it would stay there. But by then I'd had 15 years, and that was sufficient, I think.
But it has, it has maintained at that level. And wow, this is fascinating. You created that.
Well, there were a lot of people that were really very interested and that were very helpful. And one of the things that I did is I looked around and said, where can I find young faculty who would really relate well to the students? Now, as a chair, I was much younger than all the other chairs. So maybe that helped, but I found, I looked for young, recent residency grads and put them in positions where they would have a lot of interaction with the students, and they're wonderful role models. And that's how it worked. Michelle Pugnair, for example, is one of those people that, she was in my department, and I had her running, I had another woman before that who left to relocate somewhere, I can't remember where. But then I asked Michelle to do it, and so she did it, and she slowly moved up in the department and taking more responsibility for student teaching. And then, her success is something I'm very proud of because she's somebody I really,
Marvelous.
yes,
Yeah.
really enjoyed.
So did you find that the type of student that was admitted, that you began to look for certain things in them in order, that would be more of a primary care physician?
I think we probably did.
Yeah.
We sort of took a variety, though, but I do remember that one day the chancellor, it was Dr. Tranquato, was looking, this doesn't talk about primary care, it talks about women, but he was looking at the numbers, and he saw that the numbers of women kept increasing. But of course the pool of women increased too. So he said to me, just how high are you going to go? And I said, well, maybe when we get to 100, I'll quit. Get 100% women. But, basically, there wasn't any affirmative action for women. They were just good.
Yeah.
And they could do it, and they were interested, and they reviewed well, and they kept climbing in their numbers. But that was relatively proportionate to how they were applying.
Now, you said that one of the things that brought you into medicine was wanting to work with people, wanting to work, I believe, with patients.
Yes.
And then it seems as if your career became more administrative. Do you find that that was something that you chose, or do you think it just started to happen?
I don't think it's something you really choose. I always had a practice. I had a practice until I left. I left UMass in 2002 and went to Harvard Medical International. And I kept a practice, but the number of days a week that I saw patients decreased, and that almost out of necessity, because you just were so busy running a department, and my department was really pretty large, in that we had 4 health centers, and we had residencies we had 2 family medicine residency programs, and one was at 3 sites and one was at 1 site. And then we had a preventive medicine residency, and we had an occupational health residency, and we had a fellowship in family medicine OB. So you have a lot, and you start spreading yourself more over the state. Plus that we were at one point, from the beginning, and I can't remember when it stopped, but sometime in the mid-90s, I think, we were responsible for the patients at Belchertown and Monson and providing medical care to those services. So as the responsibilities grew, the amount of clinical work I did dropped, as I saw in my fellow chairman. That happened to all of us.
Yeah.
And for you to maintain a relationship with patients, you like to be more available to them. What I found interesting is the patients that stayed with me. I had people that stayed with me that I was now taking care of, the children of the children that I had originally taken care of. And they just said, oh, this is fine. You know, we know you're not available all the time, but that's okay. After a while, I didn't think it was okay. I thought that I was, that for the patient's sake, they needed somebody who was more available than I was.
So when you, forgive me here, you said you maintained a private practice up until
At the university.
At the university up until 2002.
Till when I left.
Okay, okay. How many days a week did you?
Well, I think I started out doing 3 half days and then 2 half days, and eventually got down to 1 half day.
Yeah.
When you're down to 1 half day, the people you have in your practice are people you know already. You know very well. You might have a lot of phone calls with them besides seeing them, because you want to keep that relationship going. They want to keep it, and you both want to keep it. But then I started doing more international work, and that even added to it. So,
What was the international work?
well, in 1990, 91, we took a sabbatical, and we went to the University of Zimbabwe School of Medicine, took our family, and so we lived there for a year. So somebody was acting chairman during that time, and then I was in a group practice, and my group took care of my families. And then I came back, and Project Hope, which was the old Ship Hope years ago. Anyway, they do a lot of sort of grassroots work, particularly in Latin America, some in Eastern Europe, some in Africa. And I worked with them as I was the William Walsh Fellow. He was the founder, and then I was the first fellow they had. And I worked with them and mostly helped them from my public health background to evaluate their programs or to design programs around maternal and child health particularly. And then I did worked with them as they developed a strategic plan. I was their sort of outside counsel to do that. So I was always involved in those things. Interestingly enough, patients become very interested in those things when you're doing that. They're very excited. We went and worked in Haiti for about 3 weeks once with our children when they were little, and patients were just fascinated by that. They wanted to see what they could do to help. They were just really interested. So when I thought, I'm not going to be available for you now for another 3 weeks because I'm gone, they sort of went, no, that's just really good work that you're doing.
Yeah. No, it's interesting. Your patients sounded very, very supportive of you.
Yes, they were.
Yeah.
They were.
Yeah.
I hope I was of them.
Yeah. Well, they wouldn't have stayed with you. They wouldn't have stayed with you otherwise. Now, you have 3 children, correct?
Yes.
So, how did you manage to have children during all of this work that you were doing?
There's this wonderful lady named Lady Elaine. The children called her Lady Elaine, Elaine DeCarroll. She came to work for us. Well, we had various people that were just terrific. Most of the time, the children were at home, and somebody came in. But Elaine, we never could have done it without her. She was with us for 15 years. She came just before our youngest child was born, and she just was she was young. She was about 27, and she never had any of her own children. She was married, but didn't have any of her own children. So she just took care of these children, and she treated them like her own. She just good to them, and she disciplined them, and she paid attention to what they were doing. But she never worked full time. We always had her. She worked Monday, Tuesday, Thursday, Friday, and we had somebody else come in on Wednesday because we felt that's what she wanted. That would work better. And we had various other people. We had a young lady from Aruba whose husband was a student at WPI, and she had a little girl, and she came and took care of the children. They would stay all night if we went away for some time, but they were just great people. And then we had an older woman who also, when they were younger, took care of them, and sometimes took care of them other times. But the idea behind that, we also then sent them to nursery school, but kept the nanny housekeeper person, was treat them well, pay them well, and they're doing something extraordinarily important in your life, in the children's life, and in their life, and just be generous.
Right.
And it works out just fine.
Yeah. Are you still in touch with Lady Elaine?
Lady Elaine, her son, let's see, he's been married 2 years right about now, almost. But he got married in Denmark, and so he had a reception here last October, and Lady Elaine was right there. And we've got great pictures. And at Christmas time, her husband sent me an email and said he wanted to get some pictures of Lady Elaine with our children, and so I sent him. I connected him from the wedding, so I connected him with the bride, with my daughter-in-law Alicia, and when Christmas morning he gave her one of those electronic photo frames, and she wrote me a note. She was just very nice, very sweet. She wrote me a note, and she said, I was opening this present, and I opened it, I looked at it, and I said, oh, that's very nice. That'll be fun to fill up and everything. And she said, and I was busy putting away the wrapping paper, and he said, turn it on. And she turned it on, and there, she said, I just screamed when I was so excited, because there she was with the children, with her 3 kids that she really helped bring up. She was just a lovely person.
As you're talking and sharing this, the one thing that UMass really has is that sense of community, that we're all in it together, and that story really kind of mirrors it.
Well, we were, I think my husband had left UMass by then, but I was involved in helping start the first daycare center they had. And even though we had sufficient coverage, we wanted the children to have that experience of like a nursery school. So we sent them 2 days a week there. And they went there, and either I'd pick them up or she'd pick them up. And but that's a real necessity for a university hospital to have.
Yeah.
And it's a good investment.
So you left UMass in 1996?
No, in 2002. After I was chairman of family medicine, I became vice chancellor dean for public health programs, international and public health programs, and then I left in 2002 and went to Harvard Medical International.
So how many, the percentage of women physician colleagues, how has that changed since you began practicing?
Oh, it's been a huge difference. There were always more in pediatrics than there were in many other, and there were always a number of colleagues I had at the university. I think we probably sought each other out, and sometimes we had dinners together and things like that. Not a whole lot, but sometimes we did. But at the leadership level, there were very few women. there was a hospital director. There were a couple of hospital directors that were women, but chairman, there were never any other chairman when I was chairman. They were women.
I suspect that having a father as a surgeon and 4 brothers.
No, I had 2 brothers and
Oh, you had
and
2
two
brothers
and
and
2 sisters.
Yep, yep. Do you feel that helped prepare you?
Absolutely.
Yeah, yeah,
Absolutely.
yeah.
Yes. Yeah. I always said that you sort of helped you deal with people.
Yeah,
Yeah.
yeah. And humor, as you said,
Yeah.
humor really helps.
It really helps a lot.
Yeah.
Right.
Yeah.
And then you had to pay attention to your department, and I happened to be quite interested in the finances. And I think that was quite different
Yeah.
than a lot of chairmen. And I would go over, and I always had very good administrators, and I'd go over the budgets with them, and so that I really knew where the funds were and how we could maximize them, and how we could use them to get new programs and things like that. And I did a lot of grant reviewing for the federal government, HRSA, which was the branch that had all the money for primary care and family medicine education. And for years and years I reviewed those grants, and then that helps you in either writing them yourself or guiding other people to write them, because our department was very successful in getting grants. And you also realized that you had to make your clinical department productive, so people had to be seeing patients and at some volume, and primary care, the way a system is set up, isn't really as lucrative, so that a university has to subsidize that, but you still can make it, you still have to be responsible, so you have to go for grant money, and you have to get some NIH money, which we were able to do, and hire some people who were doing epidemiology and people that were doing preventive medicine and other things. You have to sort of expand your horizon. But because we were Department of Family and Community Medicine, that was the name at the time, we worked on getting an MPH program going, which is now still going. I still teach in that at UMass. So it was the new things that I particularly liked doing. After a while, maintaining is not my great interest.
Well, you seem to have a remarkable business savvy of understanding what makes a system tick, what is important, getting those funds, getting that blood going and flowing through a system. Where did that come from?
I don't know. I think it must have just come from home, because it wasn't something I had learned in medical school. But I did take a fabulous course at Harvard School of Public Health for clinical chairman. And when I got there, you apply, and then they take maybe 30 people. It's small. And when I arrived, the first day, you arrive on a Sunday afternoon, I walked in, and they said, "Hello, Dr. Eckhert, how are you?" And I said to myself, well, I'm the only woman in this group, aren't I? And I was.
Yeah.
And because there weren't that many women that were chairmen at that time, from anywhere.
Yeah.
So they taught us a lot about finances, and not just finances, but utilization of resources and thinking things out. Like, people always want to expand their clinic, or they want to expand their ORs or something, but you really need a study to show you, well, what are the peak flows, and when are these rooms actually vacant, and when are they being, people are waiting in line to use them out, and setting up systems that work, and those kinds of things that were really eye-openers.
Yeah.
And I guess getting an MPH also helps you in some of the courses you take that are, you're worried about accomplishing a project, and what are the resources you need, and how do you get them.
Yeah.
So you pay attention to that. Plus my fellow chairman. It's there's a bit of competition between chairs. You know, everybody wants their department to be the best that it can be, and you want your family medicine to be the best family medicine department, but you also want it to stand as best it can against some of the other departments, and not. I had enough pride in us as a group
Right.
that I wanted to see that happen,
Right.
and so did my colleagues that I worked with.
Physicians.
Yeah.
How is managing female physicians versus male physicians different?
It's an interesting question, because to me it's not the gender as much as it's the individual.
Okay.
Because I don't think you can totally classify them. You usually, people often say, you know, child care, all that goes with the women, but I have a lot of men that really took huge responsibilities for their children that shared. The one thing is maternity leave, and then that was all defined. And so I was more interested in the individual, how they were going to progress, how productive they were for whatever they were supposed to be doing. Their productivity might be in seeing patients, but it might be in grant writing, or it might be in teaching. And trying to look at the strengths of your people and say, what's the best way to get this task accomplished? Who should be doing what? And I don't think that was so much gender-based.
How do you feel that your fellow chairmen in different departments managed in a similar fashion to that? In other words, that they viewed the individual.
Well, I was asked at one point, I have to reflect on this, because I was asked at one point to look at all the women's salaries in the university I was in charge, and they were not being paid the same. So they weren't looking at it. And I guess in reflecting back, there were some women, I think women have a bit of a tendency to think they're not ready for something. So you might ask them, okay, why don't you direct this? I'd like you to be the director of this. Well, I'm not quite ready. I really need X, Y, and Z. In the meantime, I had some gentlemen that would come to me and say, I should be doing X, Y, and Z. I should be directing this or that. And they were not ready, but they thought they were ready. So I think women are a little bit hesitant. I had one experience with the Department of Pediatrics, because I had a joint appointment in peds. And the Department of Pediatrics faculty, women faculty, called me and said, could I have breakfast with them? And they just wanted to talk about what it was like to be a chair and whatever. So I said, sure. So we got together for breakfast, and so and they were interested in what I did. And I said to them, okay, who in this room would like to be a dean? One person raised her hand. And I said, okay, how many of you would like to be chairs? And nobody raised their hand. So I said, well, why don't you want to be chair? Because to be a dean, usually you have to be a chair. Not it's a route. You have to have some leadership position before you become a dean. So they said, well, actually, we look at you, we see what you do, and we think you work too hard. We think your hours are too long. We know you're here early and you stay late. And that doesn't really appeal to us. So I think it took another group of women to a little be more comfortable. I also had an extraordinarily supportive husband,
Right.
which you have to have,
Yeah.
or partner of some, you have to, and you have to set up systems, backup systems. That, I mean, we always had, yes, we had Lady Elaine, but we had a backup. If she was sick, then we
Yeah.
knew what to do,
Yeah.
how to handle it. If she went on vacation, we know how to, we were gonna, and I think too often it does fall on the woman in many respects, and too often it's sort of shaky. They don't have the backup. I sort of believe in redundancy.
Yeah. Yeah. But it also, to me, sounds like you have an internal drive
Oh, I do.
that is Yeah, that is unique. What, when you are presented with a project or something, does it become, how do you focus on that when all these other things start to come and hit you? How do you maintain?
Well, you set your priorities. And probably the most interesting thing that I've done, at least in the last 5 years, when I went to Harvard Medical International, which is now called Partners Healthcare International. So I've been there 10 years. The Our job was to work with international communities that came to us and asked for help. So one of the things that happened was Lebanese American University came to us and said, we're trying to decide if we want to have a medical school or not. Could you help us? So 4 of us went over, and this was in 2005, and we did a study, and they wanted to know if they should have a hospital and a medical school. We said they were an older university from 1835. And we said, it makes sense for a medical school, but doesn't make sense to build a new hospital. You should be able to work with some of the hospitals here. Well, anyway, make a long story short, we worked with them for a number of years. We helped them find a dean. I worked with the dean. We helped design curriculum, did faculty development with some other people from my office. I was in charge of this project because that's how we do it. Somebody's in charge of it. The dean started in 2007, I think, and then he left in 2010. The first class had finished 1 year, and he left. The president of the university called me. I knew him very well, and he said, "Okay, would you be the dean?" So I said, "Oh no, but I'll come over, and because it was in August, and the students were starting at the end of August, the new class, so the second class." And I know that it's an uproar, so I'll go. So I went, and of course then they convinced me that I should become the dean. So I then became the dean of the medical school, which I did up until November. So I did that for a couple of years. I traveled back and forth. We had an apartment in Beirut. And so the task then, I knew exactly what the task was. So I set my priorities, but I still was working back here because I didn't want to give up my job because I didn't know when they would find a permanent dean. It took a little over 2 years. And so you sort of set your priorities and decide, okay, there's a whole body of work that needs to be done, but what's the core work that has to be done? And how do I get the fundamentals right? So what are the principles we're functioning on? And then how do we operationalize those? How do we get everybody to buy in and operationalize them? And then we get those principles, and then that builds on the courses you're teaching, how you teach them, the methods, the assessment, the whole thing builds on this. And what we were doing in Lebanon was we're changing their curriculum. We're going from a very standard curriculum to a much more problem-based, hybrid kind of curriculum, small group learning. They're not used to this. We're doing clerkships in models they wanted an American model, but modified so that it would work for Lebanon. So, and you have this whole group of people that you work with, some of whom are extraordinarily bright and motivated. Some are skeptical. Some probably are more than skeptical on the negative side. But bringing along together and getting them to buy in, and that to me is very exciting. That's what sort of what I did when I took a department that was in trouble at UMass and got it so it was flourishing. I was able to utilize what I learned there.
To me, it sounds like part of what allows you to be so successful is understanding systems, understanding people, the individual, what motivates them, how to get what's best out of them, as well as systems to figure out what motivates a system, what a system needs to flow. Is that accurate in your
I
approach?
think it probably is. I had a real interesting experience when I was at UMass, but I was not chairman of family medicine, so I was doing this public health international medicine Chancellor called me and said, would I do him a favor? And I said, oh, sure, what would you like? And that's the other thing, is I have a tendency to say yes rather than no.
Okay.
Sometimes I don't even know what I've said yes to, which could be a mistake and probably has been, but I have a tendency. Chancellor wants you to do something? Sure, I can do that. Not a big deal. Well, what he asked me to do was be chairman of radiology, which I did for 5 months at UMass. That was a very interesting, a very good learning experience for me, because I knew, he said, I want you to do it because you've run a department successfully before. You know, this one is in an uproar right now. The chair had left. They had a new hospital, a new health systems executive, and there was a clash there between the acting chair. So would I do it? So I said, oh, sure. So I interviewed somebody, and I interviewed the former chair, who was a friend of mine, who had retired, and sat down, and he sort of said, this is the lay of the land, which is very helpful. And then I interviewed the person who was head of the clinical system, who told me there was this one faculty member who was impossible to deal with. I said, okay. So I'd been a chair before, so I knew there were people impossible to deal with. I was, maybe sometimes I'm one.
Yeah.
But anyway, so I met with the radiology department, and they were very gracious. Here they're getting a pediatrician who's running their department, but they were happy. Okay. We'll do this way. Okay. So they knew me because I'd been at the hospital for years. I didn't know them all, but I knew a lot of them. So we sat down, and I said to him, okay, I know you have a lot of problems, so I want you to come in and tell me your problems, but don't bother to show up unless you've got some suggestions for solutions, because we can't solve these. We got to solve it together. So the one person shows up at my door, and I said, and I didn't know him. I said, it's very nice to meet you. I understand you're one of the big problem solvers here. And he turned to me and he said, no, I'm one of the problems. I said, well, I figured that too. And he was the person that they had told me what would be such a problem. He turned out to be, because I wanted to involve him, because I knew that he had the rest of the faculty behind him, which is why they were saying he was a problem to them. He had the faculty. So I said, okay, how would you go about doing this? And then I'd say my opinion, he'd say his, and then we'd negotiate it out, and he'd help me, and I'd help him. And sometimes I noticed that we would have agreed on something, and then at a public meeting, he would say, well, we can't do that. And I knew he was saving face, and you just say to yourself, why is he doing that? That's why he's doing that. But in the end, we're going to I trust him enough. I trust these people enough. We will get where we have to go, but they may have to do something in the middle that looks a little strange. And they may often, I learned, have to feel like they've beaten you a little bit. And that's perfectly fine.
Yeah.
I learned that because I learned that the hard way. By the first time I let somebody go.
Yeah.
And, then I negotiated with them later. But I think most people are trying to do the best they can, but they also need to feel valued and respected. And they just may not fit into what your goals are, but that doesn't mean they're not valuable people. And how can you help promote them to maybe not stay in your own department, but so that they're doing what they love somewhere else? You don't want to just, they're valuable. People are valuable.
There's a generosity of spirit there. There's it sounds to me like a inability to understand ego, your own and others, and knowing when you need to do this to it, kind of put it to the side, your own, in order to get, yeah. Where do you, kind of looking at where we are in this country with our healthcare system, where we are presently, where do you hope we go?
Well, I wish we had a national health insurance program that with a single payer. What probably worries me the most is I think there's too much medicine for some people, way too much medicine for some people, and clearly not enough for other people. And we are a nation that is so used to having sort of instant gratification that we want that in medicine too, and I think it's harmful. It's harmful from two reasons. A patient comes to me with a problem, and if they come early enough, I can't always figure out what that is. Okay? But if I wait a few days, or a week, or some amount of time, depending on what this is, the evolution of the disease is much more obvious. If I act too early, and you have different patients, and some patients don't want you to do anything. Yes, they're happy. They just want to know what are the possibilities, and I'm willing to wait and see and not intervene too much. As soon as some things you have to intervene right away. You know what it is, or you know that it's very serious, even if you're not sure exactly what the diagnosis is. And you have to do your interventions and your diagnostic studies. But I think as a public, we're used to that instant cure and instant knowing what it is, and I think we get over-treated a lot. And I find that a real shame. Much more is being written about that. You know, that there's this whole discussion now about not calling some of these precancerous lesions cancer. I don't know if you've read about that, but because it labels people and it worries people when in fact, you know, maybe those things are not going to be something you really have to worry about. And it's not like you're trying to hide something from your patient. You're trying to work with your patient and guide them into making some good decisions for themselves that are not so much intervention. I really am worried about that. When you had the same amount of resources, you could give those resources to people who are not getting any of those screenings or any of those treatments that are just out there. They may not be on Medicaid. They may, be self-payers. Massachusetts is a little different, but I'm looking at this from a national. The other thing that's interesting, because I work overseas all the time now, is the desire by many countries to emulate our system. And some of it is fantastic that they want to emulate it, but some of it is not. Some of it is very much money-based. And they see that, physicians in the United States do much better than almost anywhere else. And they see that, and they want to duplicate that system, but they may not be duplicating the quality that goes with it.
Okay. Now, with the single payer system, would you have any concerns with the implementation of it?
Well, it's interesting. I don't think that the average U.S. citizen actually realizes how much the federal government is already involved in paying for health care. They pay for Medicare. They pay for Medicaid. It's a federal and state partnerships, in part. They pay for the military and certain federal employees, so that the majority of the money is coming from the federal government. So why are we so worried about that? They don't have the overhead that the private insurers have. They have a huge overhead. So I think it could be worked out. I think there are huge lobbies by all sorts of healthcare providers and insurers and pharmaceuticals and medical devices and all sorts of healthcare workers that think we're going in the wrong direction, but I don't happen to believe that.
So is it those lobbyists, those different groups would almost be the check in the system of having just one? I mean, it sounds to me like it's already happening.
I
what
think
you're
it is.
saying.
Yeah, I
And we
think
already
it's
have
happening
checks
more.
in the system.
Yeah.
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 But where does that leave
But
the
if we
physician?
could make it, um, the physicians probably didn't step up early enough. You know, they fought Medicare and they fought Medicaid. So then they fight system when, if you put your patient, why don't we put our patients first? I think on an individual basis we do, but maybe as a group we don't so much. You know, we like to think that the person in front of us, we're really doing the very best we can. But if you look at some of our results, they don't look so good. You know, and that's why we didn't fill in the gaps. So for example, if you're looking at diabetic patients and there's protocols for which you should take care of diabetic patients or a patient that had a myocardial infarct, and a high percentage of patients are not getting what's necessary. Okay, they're not getting the diabetic eye screens, for example. They're not getting those things. Somebody's going to step in because we didn't. So that worries me a bit that we didn't. And I'm hoping the next generation will be better than we were. And many of them are getting much more of a training in public health and preventive medicine and some of the things that make them look at populations than we ever got. And medical schools are concentrating more on that, which I think is a good thing. I also think physicians should allow, we should think, it's very expensive to train a physician. Very expensive, right? So then we should be working at the top of our game. And a lot of what we do, and a lot of what I did, could have been done by nurses. And they would have done a fine job. They would have done a very good job. And I think we should look at that system that maybe we should look at what do we do well and do that well, and what do other professions do well and let them do that well. And really make it a real team effort. And the physician doesn't always have to be the team leader either.
Yeah. It's tough to let that go.
It is, absolutely.
Yeah.
Absolutely.
Now your son, my understanding is that he's a medical student.
Yes.
Yeah. What year is he?
Oh my goodness, that's an interesting question. He has, he's in his PhD part now.
Okay.
He's an MD PhD student. He has one more year of medical school to go, and
Okay.
he's doing, so I think he'll probably graduate in 15.
Okay.
15.
So when he decided to become a physician, when he was going away, what words of advice did you give him?
Find something you love. Yes. Because the field is so broad and so exciting that there's just amazing amount of work to be done that you can do. And just find your niche and do that the best you can. And you may not know at this age what your niche is either. I mean, I got very involved in academic medicine and the organization of it and the licensing of physicians here for the ECFMG, which is the foreign physicians coming. Because I've been working overseas and I was interested in what were the standards and sat on that board and chaired that board. So medicine takes you places that you didn't think it would take you. And you can go there if you want. And I did. You know. And I missed other things. I didn't have that same larger patient practice, long-term, real involvement with patients that other people did. And I admire them for doing that, and hopefully that's where they were happiest, and that's where their talents lay.
What is your philosophy in life? I know that's a really tough question, but how do you, what drives you? What gets you up in the morning and what gets you out there?
It's just so exciting out there.
Yeah.
I mean, there's just so much, you know. While you were interviewing my husband, I was, you know, a bomb went off in Beirut
Yeah.
today. And So I was writing my colleagues. Now, I think they're safe because I know where it went off and I know where they live and what time it happened and everything. So I just assume that they are, but you don't want to just assume, you want to find out. But to think of the pleasure it was to work with this whole group of other people, and I'm supposed to be going back in September, the end of September. It was just a very wasn't always easy relationship, but it was a good relationship and it was a respectful relationship. And I learned a lot from them, and hopefully vice versa. So it's a big world out there. It's just too many exciting things are going on. People are constantly asking me, why don't you retire? Well, I don't know what that would be like. You know, I don't work as much as I used to, but I'm now, the other project I'm working on now, I was in Haiti at Paul Farmer's Hospital in June. We were doing some training for people to train family medicine residents, and that was a whole lot of fun. And then, you know, you work with them, what do you want, and you have to figure it out and negotiate together what would be best. And then I'm working on a public health program in Saudi Arabia. And so, you know, I go to Saudi Arabia now and I have to put on an abaya and meet really different people that have a different outlook on life and figure out how that happens and why it works and what's going on. So I just like it.
It's the excitement of
Yeah.
of life and the unknown. Do you have any parting advice for medical students, and do you have anything specific for women medical students?
I had a discussion with one of my children the other day, and because I've heard a lot of young people use the term life-work balance. And I said, that doesn't make sense to me, life-work balance. Isn't it work-play balance that we're talking about? Because when you're home, especially when your children are little, you know, you have the laundry and the cooking and the cleaning. You've got all this stuff you have to do. When people talk about life-work balance, they usually talk about work is where they're, you know, where you're earning your money, that kind of work. But in fact, work is both home, your community, and your work. But play is also. So you want to enjoy your work. You're not playing at your work, but you're enjoying it, and you're creative, and you're adding something to it. So that's the work part. And then the play part is, and you're also working at home. And then the play part is, you know, the fun that you have with your colleagues, what you have with your family, what you have at home. So I don't like to think that when you're working, you're not living, because you are. And we are fortunate in our profession, and many people are not, to have an opportunity for such a contribution to society and to our patients and to our colleagues, that work is enjoyable. So to me, it's a work-play balance, not life. It's life is, your work is part of your life.
Right. Oh, it's excellent.
Well,
Thank you so much for your time. Thank
You're welcome.
you.